What the study says.
Imagine this, if you will. It's the middle of the night, dead quiet, and suddenly you hear this piercing scream. It's your child.
Oh, that's every parent's nightmare scenario.
Exactly. You race in, heart pounding, and they're bolt upright in bed, eyes wide open, staring, but totally vacant,
Unresponsive.
Completely. And they are screaming like they're seeing absolute terror. You see their chest heaving, breathing super fast, sweating.
A little autonomic response kicking in.
Yeah. And you try to hug them, comfort them, but they might even push you away, still caught in whatever horror this is.
Like they're trapped somewhere else.
Right. Then, just as suddenly, it stops. They lie down. They're asleep peacefully. And the next morning...
Nothing. No memory.
Zero memory. That feeling for a parent, that helplessness, it's just bone-chilling.
It really is.
Okay, so let's try and unravel this. We're doing a deep dive today into this really profound and often scary thing called sleep terrors.
Or night terrors, people call them that too. Or the clinical term, pavor nocturnus. And it's fascinating, isn't it, how often people just say, oh, it's just a really bad dream.
Yeah, they write it off.
But it's really not the same thing at all. That's a big misconception. Sleep terrors are actually a distinct sleep disorder. They fall under this category we call disorders of arousal. Very different from your standard nightmare.
Okay, so our mission here is to dig into the latest research. We want to figure out what exactly these things are, who gets them, why they even happen.
And importantly, what can actually be done.
Yes, what can be done to manage them, not just for the person having the terror, but for the whole family, because it affects everyone.
Definitely.
So to really get a handle on night terrors, we need to understand what's actually going on, what defines these really dramatic episodes.
Well, clinically, we describe them as abrupt but incomplete awakenings from deep sleep. Yeah, think of it like this. Your brain is mostly in that really deep stage, N3 non-REM sleep, sometimes N2. But then part of it tries to wake up suddenly. But it doesn't quite make it to full wakefulness. It's this weird partial emergence.
And that partial emergence looks terrifying from the outside.
Oh, absolutely.
Yeah.
It's incredibly dramatic. You see that sudden arousal, usually with intense fear, that inconsolable crying, the screaming we talked about.
Mm-hmm.
And there's often a lot of physical movement, too. Sitting bolt upright, jumping out of bed, sometimes running around frantically, even trying to bolt out of the room.
Wow. Oh,
Bolting. Yes. And here's something really important for caregivers. Trying to physically hold them down or restrain them.
You'd think that would help.
Right. But it can actually make things worse. It can paradoxically ramp up the agitation, sometimes even leading to aggression because they're just reacting instinctively in that confused state.
Okay, good to know. Don't restrain.
Exactly. And during the episode, the body's involuntary systems are just on high alert.
Yeah.
Pupils dilated, heart-racing tachycardia, breathing fast tachypnea, sweating, flushed skin, muscles tensed up.
All the classic fear responses.
Pretty much. And the person is deeply confused, disoriented. And the key thing, afterwards, usually total amnesia for the event, a blank.
No memory at all.
Sometimes they might recall a vague, scary image or feeling, but it's not like a coherent dream narrative you get with a nightmare.
And when do these typically happen?
Usually in the first third of the night, say 60 to 90 minutes after falling asleep. That's when deep sleep is most prominent.
And how long do they last? It feels like forever when you're watching.
It probably does, but typically it's seconds to a few minutes, though they can last longer, occasionally up to an hour, but that's less common, and usually it's just one episode per night.
Okay, so here's where it gets really interesting, differentiating them. You mentioned nightmares. What's the absolute key difference that people should grasp?
It really comes down to the sleep stage. Nightmares happen during REM sleep, rapid eye movement sleep.
All right, the dreaming stage.
Exactly. That's when we have vivid, story-like dreams, usually later in the night. And when you wake up from a nightmare, you remember it, often quite clearly.
You can tell someone about it.
Precisely. And you're generally easier to wake up fully, you can be consoled, and you don't usually see that same level of intense physical panic and autonomic overdrive.
Okay.
Sleep terrors, though, they burst out of NREM sleep, that deep, non-dreaming sleep, characterized by that amnesia, the difficulty waking the person, the inconsolability, and all that intense physical stuff. It's a fundamentally different neurological event.
That makes a lot more sense. Not just a bad dream.
Not at all.
So let's talk numbers then. Who actually gets these? Is it common?
Well, it's much more prevalent in children. The numbers vary a bit depending on the study, but estimates range from, say, 1% to 6.5% of kids age 1 to 12. Some reports go even higher, maybe 14%, or even up to 25% in some samples.
Wow, that's quite a range, but potentially quite common then.
It is, especially during peak years. The highest frequency tends to be between ages 4 and 12, particularly around 5 to 7 years old.
Okay.
Then the good news is it usually declines quite significantly with age. It becomes pretty uncommon after puberty hits.
And in adults?
Much rarer, maybe around 2.2% for ages 15 to 64, and it drops even lower to about 1% in folks over 65.
Interesting.
Lifetime prevalence, meaning the chance of having at least one at some point, is estimated around 10%. Oh, and there's a slight gender difference in kids. Seems to be a bit more common in boys.
But not in adults.
No, that difference seems to disappear in adulthood.
Okay. Now, if we connect this back to the brain, you mentioned it's a different neurological event. What's actually going on up there? You use the term sleep state dissociation.
Yeah, that's the prevailing theory. It's like parts of the brain are trying to do different things at the same time. Some regions, like the parts responsible for conscious awareness, memory formation, think the cortex, the hippocampus, they effectively stay in that deep non-REM sleep state.
Still asleep.
Right. But meanwhile, other brain areas, especially those involved in movement, the motor cortex, and strong emotions, particularly fear the limbic system, the amygdala. They suddenly become active. They sort of wake up.
You have this bizarre mix.
Exactly. You get the physical actions, the intense emotional display like fear, but without the conscious awareness or the ability to form a memory of it. It's a state of dissociation between different brain functions. Researchers also see some abnormal patterns in brain waves, like unusual bursts of slow-wave activity right before these episodes sometimes.
So the brain signals are getting mixed up, but what causes that mix-up? You mentioned it's often a combination of things, this cascading interplay. Can you walk us through that model?
Sure. Think of it in layers or stages. First, you have predisposing factors. These are things that make someone more vulnerable in the first place.
Like genetics.
Genetics are a big one. There's a strong family link. If one parent had them, the risk goes up. If both parents did, it's significantly higher. There are even specific gene markers linked to it. Also, neurodevelopment plays a role. Kids naturally spend more time in that deep, slow-wave sleep. Plus, their brain circuits that normally inhibit or control these kinds of abrupt arousals are still maturing. That's partly why it often resolves with age. The brain develops, refines its connections through synaptic pruning.
So brain maturity is key.
It seems to be. Some theories also involve potential imbalances in neurotransmitters like serotonin. So that's the predisposition.
Okay, stage 1. What's next?
Stage 2 is priming factors. These are things that increase the body's need for deep sleep, making an episode more likely if you're already predisposed.
Like being really tired.
Exactly. Sleep deprivation is a classic priming factor. It increases your sleep pressure, making you go into deeper sleep when you finally doze off. Also, certain substances that suppress the central nervous system can deepen slow-wave sleep, things like some sedatives, even certain stimulants paradoxically, or other medications.
Okay, so predisposition plus something that deepens sleep. And the final piece.
Stage 3, precipitating factors. These are the actual triggers, the spark that ignites the episode by causing a sudden attempt at arousal from that deep sleep.
What kind of things?
It could be lots of stuff. Environmental things, like a sudden loud noise, or internal things, like medical conditions. Untreated obstructive sleep apnea is a big one.
Ah, OSA.
Yes, or restless leg syndrome, even acid reflux bothering you during sleep. Other triggers can be things like having a fever, a really full bladder needing to wake you up, intense physical activity earlier in the day, or significant emotional stress. Very rarely, a specific type of brain lesion could be involved, but that's uncommon.
So it's this combination, the underlying risk, the increased deep sleep, and then something that tries to wake you up just enough to trigger the terror instead of full awakening.
Precisely. It's that cascade.
That paints a really clear picture. Now, this brings up a really, well, almost a philosophical question, maybe. Is our modern way of life, specifically how we handle sleep with kids, potentially contributing? There's this fascinating evolutionary idea, the environmental mismatch hypothesis.
Ah, yes, the mismatch idea. It's really thought-provoking. The core concept is that maybe some modern practices, particularly solitary sleeping for infants and young children, clash with our evolved biology.
How so?
Well, if you look at our evolutionary history and our close primate relatives, in many traditional human societies, even today, co-sleeping, meaning the caregiver and the child sharing a sleep space, Often the same bed was, and is, the norm.
It was standard practice for millennia.
Absolutely. And from an evolutionary standpoint, it makes sense. It offered huge survival advantages. For a vulnerable child, having a parent right there dramatically reduced the risk of, say, predation.
A scary thought, but realistic back then.
And it's interesting, isn't it, that the vague things kids sometimes report after a terror often involve threats, monsters, things trying to get them.
Oh, yeah. I hadn't made that connection.
Beyond just safety from external threats, co-sleeping has physiological benefits too. Shared body heat, better regulation of breathing and heart rate, easier access for breastfeeding, which also promotes sleep regulation, and, crucially, it makes both the infant and the parent slightly easier to arouse if needed.
Okay, but many parents today, especially in Western countries, are specifically told not to co-sleep due to safety concerns, like SIDs. How do we square that?
That's the crux of the mismatch, isn't it? Solitary sleeping is very much a culturally derived trait in many Western nations. It's often actively encouraged through things like sleep training, which sometimes involves limiting parental responsiveness to nighttime cries.
Right.
And yes, the American Academy of Pediatrics, for example, historically cautioned against bed sharing due to the risk of SIDs or accidental suffocation smothering. But it's really important to look closely at that risk.
What does the data show?
Well, the actual rates of smothering are very, very low. Some studies put it around 0.1 per 1,000 live births. And a significant number of the cases that do occur involve unsafe circumstances, like a parent being impaired by alcohol or drugs, or sleeping on a sofa, which is inherently unsafe.
So for responsible parents following safe co-sleeping guidelines.
For responsible parents, on a safe sleep surface, the argument is that the potential benefits of close proximity sleeping, like maybe reducing the stress that could contribute to terrors, promoting secure attachment, improving physiological regulation, might actually outweigh the very low, often preventable risks. It becomes an informed choice rather than a blanket prohibition.
And you mentioned other benefits too, longer-term ones.
Yes, beyond just sleep patterns.
Sure.
Some research has suggested potential long-term psychosocial benefits linked to co-sleeping in childhood.
Like what?
Studies, often retrospective, have found correlations where adults who co-slept as children reported things like higher self-esteem, more comfort with intimacy later in life, and greater overall life satisfaction. Some even suggested they were less dependent on parents, perhaps fostering a secure independence.
That's counterintuitive to what some might think.
It can be. It challenges the idea that solitary sleeping is necessary to foster independence. This research really makes you wonder if pushing for solitary sleep very early might be, in some ways, maladaptive from a psychological perspective. You even see shifts now, like the AAP recommending room sharing, baby in the same room but separate sleep surface, for the first 6 months to a year, acknowledging the benefits of proximity, even if they still caution about bed sharing itself. Co-sleeping might offer even more.
Okay, so shifting gears slightly, back to the immediate impacts of the terrors themselves. We know they're distressing, but can they be physically dangerous?
They potentially can, yes, if the person is thrashing violently or especially if they get out of bed and run around in that confused state.
Right, the bolting you mentioned.
Exactly.
Yeah.
There's a real risk of accidental injury, bumping into furniture, falling downstairs, even running into a window or out a door if things aren't secured. Property damage can happen too.
And the impact on the parents or caregivers.
It's huge. Beyond the immediate fright, it causes significant anxiety and distress. It disrupts their own sleep, obviously, leading to fatigue and impacting their daytime functioning, their mood, everything.
It really ripples outwards. And what about longer-term implications for the person experiencing the terrors? You touched on the brain state, but does it link to overall mental health?
What's fascinating and concerning is that, yes, there seems to be a connection, especially when terrors are frequent or persist. Individuals with sleep terrors are definitely at higher risk for things like daytime sleepiness and fatigue, which makes sense.
Sure.
But studies also show links to increased rates of anxiety and depression. And one particularly significant finding relates to early childhood. A higher frequency of sleep terrors in young kids, say preschoolers age 4 or 5, is significantly associated with more emotional and behavioral problems.
What kind of problems?
Specifically what psychologists call internalizing problems. Things like being more anxious or depressed, more emotionally reactive, having more somatic complaints like tummy aches or headaches that might be stress-related.
And this link holds up even if you account for other things.
Yes, researchers found this association remained even when they controlled for other factors, like the mom's own depressive symptoms, or how much sleep the child was actually getting overall. It suggests that frequent sleep terrors might be an early marker, maybe a warning sign, for underlying emotional vulnerabilities or difficulties.
That's really important for parents and doctors to know.
It is. And while full-blown psychiatric disorders aren't common causes in very young children, in adolescents and adults who continue to have sleep terrors, there is a stronger association with conditions like PTSD, various anxiety disorders, and sometimes even suicidal ideation.
Okay, so given all this, how does a doctor actually diagnose sleep terrors? You said it's mostly clinical.
That's right. The diagnosis usually relies heavily on getting a really careful history, talking to the patient if they're old enough, or more often, getting the detailed description from parents or a bed partner.
What kind of questions?
You want to know exactly what happens during an episode, the timing, when in the night does it occur, how often, how long does it last, what's their level of consciousness like during it, crucially, what do they remember afterwards, and are there any daytime symptoms, like excessive sleepiness?
And video can help.
Oh, immensely. If parents can safely get a video recording of a typical episode on their phone, that can be incredibly valuable for the clinician to see the characteristic features. It helps differentiate it from other things.
Like seizures.
Exactly. Or other sleep disorders. So part of the process is also ruling out those other possibilities, making sure it's not nocturnal seizures or that underlying conditions like sleep apnea or restless legs aren't contributing or mimicking the symptoms. We also ask about medications, stress levels, any recent changes.
Do they usually need a sleep study, that polysomnography?
Generally, no, not for a typical case of childhood sleep terrors.
Yeah.
It's usually not mandatory. However, we would recommend a PSG if the episodes are atypical in some way.
Atypical how?
Like if they start really early, before age 2, or much later after age 10, if they last a very long time, say over an hour consistently, if they happen very frequently, like more than twice a week, or if there are particularly violent behaviors during the episode that raise safety concerns.
Okay.
A sleep study is also important if we suspect another underlying sleep disorder that needs diagnosis and treatment, like obstructive sleep apnea, or maybe even certain types of nocturnal seizures that can sometimes look similar.
Got it. So once it's diagnosed, what's the first step in management, especially for those distressed parents?
The first line, and often the only line needed, is behavioral management. And the absolute cornerstone of that is parental and family reassurance and education.
Just explaining what it is.
Yes, explaining the nature of sleep terrors, that they are generally benign in children, that they're not remembering it or suffering psychologically during it in the way it looks, and that most kids do outgrow them. That alone can massively reduce parental anxiety.
That makes sense. Knowledge is power.
It really is. Then we focus on optimizing sleep hygiene, consistent bedtimes and wake times, a calming routine, and creating a safe sleep environment is paramount.
How so?
Removing any potentially dangerous objects from the bedroom, maybe putting padding on sharp corners, securing windows and doors, maybe even putting a mattress on the floor if they tend to jump out of bed, just making sure they can't hurt themselves if they do become active.
And reminding them not to intervene physically.
Crucial reminder, advise bystanders, parents, siblings, not to try and physically restrain or forcefully wake the person during the terror. It doesn't help and can escalate things into that aggression we mentioned. Just stay nearby, speak calmly if at all, and ensure safety.
Okay. What else on the behavioral front?
Addressing those precipitating factors we discussed. Avoid known triggers like severe sleep deprivation, excessive caffeine or alcohol, more relevant for adults, manage stress, and importantly, treat any comorbid sleep disorders. If sleep apnea is triggering the arousals, treating the apnea can often resolve the terrors.
Right. Treat the underlying cause.
Exactly. Now, for episodes that are frequent and happen at a very predictable time each night,
Like clockwork.
pretty much, there's a technique called scheduled awakenings.
How does that work?
You identify the typical time the terror occurs, say 90 minutes after sleep onset. Then, you gently wake the child or individual about 15 to 30 minutes before that time. Just a light touch or a quiet word, enough to fully arouse them briefly.
Just wake them up fully for a moment.
Yes, just until they're clearly awake, then you let them go right back to sleep. The idea is that this brief awakening disrupts the transition into the deep sleep stage where the terror was about to occur.
And you do this every night.
Consistently, yes, for about 1 to 4 weeks. It can be very effective at breaking the cycle for predictable terrors. There are even some modern devices like vibrating pads under the mattress timed to go off that can do this automatically.
Interesting. Any other non-medication approaches?
Yes, other things sometimes used include hypnosis, relaxation therapy techniques, or psychotherapy, especially if there's significant associated distress, anxiety, or if underlying psychological factors seem to be playing a role.
That's a pretty comprehensive toolkit just with behavioral and safety measures.
It often is. For many, especially kids, this is enough.
But what if it's not? What if the episodes are really severe, causing injuries, or just incredibly disruptive despite these measures? Is that when medication comes in?
Yes. Pharmacologic interventions are typically reserved for those situations, frequent, disruptive, severe episodes, or when there's a real risk of injury.
What kind of medications are used?
Clonazepam, which is a type of benzodiazepine, is probably the most studied and often effective. It works partly by suppressing that N3 deep sleep and reducing the fragmentation or arousals from it. It's usually given about 60-90 minutes before bedtime at a low dose. If used, it's typically for a defined period, maybe 4-6 weeks after the terrors resolve, and then it needs to be tapered off slowly to prevent rebound episodes.
Are there other options, maybe ones people feel more comfortable with, especially for kids?
There's growing interest in L5-hydroxytryptophan, or 5-HTP, which is a precursor to serotonin. Some pediatric studies have shown really positive trends, like significant improvement rates, maybe even up to 84% in one study. Because of this, some experts are proposing it as a potential first-line pharmacologic option for children, given its generally better side effect profile compared to benzodiazepines.
5-HTP. That's available over the counter, isn't it? Though people should still talk to a doctor.
Absolutely. Always discuss with a doctor before starting any supplement or medication, especially for a child. But yes, it's accessible. Other medications sometimes used, though often second or third line, might include certain tricyclic antidepressants like imipramine or SSRIs like paroxetine, sometimes mirtazapine, or even melatonin in some cases. But clonazepam and potentially 5-HTP are the more commonly discussed options specifically for terrors.
Okay, so we've covered a lot of ground here. We've journeyed through what sleep terrors are, why they happen, the brain science, the triggers, the evolutionary angle, the impacts, and how they're managed. It's complex, but understandable.
It is, and the main takeaway for most childhood cases is reassurance.
Right. You said the prognosis is generally good.
Yes, for most children, especially those whose terrors started in early childhood, the outlook is very positive. They tend to simply outgrow them, usually by late adolescence, as their brains mature.
That's definitely comforting news for parents listening.
Absolutely.
So to wrap up, what's the final thought you want to leave our listeners with? Something provocative, perhaps?
Well, if we circle back to that evolutionary mismatch idea, the thought that maybe our modern habit of solitary infant and child sleep is out of sync with our biology. And we consider the potential benefits of closer sleep proximity, not just for maybe reducing terrors, but for broader psychosocial well-being. It really prompts a bigger question, doesn't it?
Which is?
How might our deeply ingrained cultural norms about sleep independence be subtly shaping children's development and well-being in ways we don't fully appreciate?
Yeah.
Beyond just sleep disorders like terrors, could a reevaluation of these fundamental sleep practices, thinking more about proximity and responsiveness, have broader positive health implications for future generations? It's definitely something to mull over.
A fascinating question indeed, challenging some basic assumptions about how we raise our kids. Thank you for that deep dive.
My pleasure.